To the panel discussion, we have eminent faculties, Dr. Ann ma'am, Dr. Vinitha, Dr. RAZEENA, and Dr. Anthony Terence, myself as a geneticist. So genetics, recurrence, related to recurrence, we have discussed 25% is the recurrence risk. We can identify a genetic disorder provided you give us time. So don't urge us, don't come with the next pregnancy without a child being evaluated. Most of the children are evaluated. I'm telling you, if there is a diagnostic dilemma, you don't have a genetic diagnosis, wait, prove it completely, prove the career status, then plan pregnancy. This can be done. This is in our hands. So plan a pregnancy, get all the genetic evaluation done, make sure that we can do some prenatal diagnosis based on your reports. If there is some diagnostic doubts, we may need to go ahead with subsequent level of testings, then we will prove. Once we prove, then you plan the pregnancy so that we can plan your pregnancy, do the prenatal diagnosis, the recurrence can be identified. Newborn and couple career screening, the career state, no, the person non-symptomatic, asymptomatic, silent carrier status is seem to be very high in SMA. It is like 1 in 40 have this SMA mutation as a silent carrier. You are silent, out of 40, 1 can be a silent carrier. Some studies shows that. So that means there is no role for consanguinity also. It is a common disease in the community itself. Anybody can be a carrier, and irrespective of the consanguinity, they can have a child with spinal muscular atrophy. To make it as a couple screening, we don't have recommendations as of now, but again now the awareness is improving so that parents or the couple are willing to get tested for common genetic disorders. When they come to us, we suggest doing this SMA career screening because of the incidence. Some disorders like DMD also will be covered. Strong consanguinity, we do look for single gene disorders, whether they have the carrier status or not. So now asymptomatic family is normal also. These families, they are coming proactively, get them tested before planning the next pregnancy. To put it in recommendation, this may take a long time, but it will be beneficial over a period of time. Definitely doing parental carrier screening will help prevent babies being born with rare diseases like spinal muscular atrophy. Newborn screening, again, we can identify the disease early. Pre-symptomatic period we can identify. That means before the muscle damage starts. So irreversible damage can be avoided if you identify early, give them treatment early. So these are all the preventive aspects. One is preventing babies being born with rare diseases, SMA, and early identification, early initiation of treatment. And these are all achievable as far as genetics point of view. These are all achievable. Well, I'll move on to the next most important topic, accessing disease management. Okay, you are trying to prevent a baby being born. Baby is born. What to do now? So accessing disease modifying treatments and therapies. I would like to get the opinion of Dr. Ann and followed by Dr. Ann, Dr. RAZEENA. So disease modifying treatments and therapies.
This has been a discovery and a journey, and it has always been hit and miss. Initially, I remember 2019 first when we said, I was like, unbelievable, we got it. But from there, we understand the reality. It was just that we could not be ignored as such a large population. So somebody said, okay, let's just give some. And that some was not chosen correctly. They were not chosen at the right time in natural history. Then there was so much of rush. We'd already had hundreds of patients with SMA at that time. So it was heartbreaking to see families fighting with each other. It was not about who had more money. It was all about who was there at the right time, right place. But it was difficult for anybody to make any choice because it was just impossible. It was not even a small drop in a bucket. So I don't know. The only way forward is trying to get generic medications developed in our country. I don't know what the model for our country would be because many of the medicines prices are coming down. I think Risdiplam is a very good example. Risdiplam that Kerala has, we were just joking and said they don't send us to jail for this. Risdiplam, which was initially 2.5 crores, then when it came down to India, they decided of the 3 companies that sell these medications, FDA approved drugs, only Risdiplam is registered in India. So I would say that I'm a great fan of gene therapy because I've seen fantastic results with it. Risdiplam, I have a bias and say that, okay, it's not so very good. But my bias is from my point of view in the patients that I have seen. But we have not been able to give it to very young treatment naive children. So when they came to India, the difference in pricing, they just had to come down by 50%, the pricing. So from whatever pricing they gave internationally, they came down to saying, okay, 73 lakhs, maximum 73 lakhs, one bottle 6 lakhs. So Tata Group was able to absorb some of the costs and through Tata Blue Tree and said, okay, you buy 2 bottles, you get 3 bottles free. So that comes to 2.4 lakhs. Kerala government did a great thing in the sense that there was a child for whom public crowd fundraising came up to 48 crores, then they came up with a lot of money, and the child unfortunately died, and because of that there was a corpus, a big enough corpus. So the government then decided, okay, wait a second, let's negotiate with the company. So they negotiated for an undisclosed amount with the company. So this is not something you or I, it is above our pay grade. But because it was a large number of patients, the company was able to come down. And whatever waivers were done, n number of children will be given, 50 or something. How many? Is there a fixed number? More than 100. So more than 100 children are able to be given medication. So now I'm not interested in, while I'm interested in that, I'm also interested in the fact that Rajasthan is following suit. Looking at Kerala, Rajasthan is following suit and is trying to match it. So now it's a challenge between each state to say, how well can we behave? But I'm giving a challenge to all of us because we are a democracy, by the people, of the people, and for the people. China is openly challenging us and is selling it for 48,000. This is legal. So currently, all my existing patients, I am sending to China, to Guangzhou University or some other university. It's legal. So they are allowed to give. That is a medicine that they are buying in bulk. So for their citizens. So they have waived off all the import duties and all of those things. So this is an agreement between governments and the company. So I don't know, I'm not saying anybody's at fault. All I'm saying is that patients are suffering, and by default, we as physicians are also suffering. We are seeing it. I don't know what the answer is. So they are knowingly giving it to Indian patients, and it's legal. They say, okay, fine, you come to Chinese soil, registered, give. That is equal to losing war, isn't it? As a country, just like our space program is, we should be proud of our space program, we should be equally proud of our health program and innovation. So Pakistan is selling it for 25,000 with no government. It's all broken and everything. And so somewhere, some crook, something, people are getting it cheaper. So let's question back.
Great question, ma'am. So, yeah, I'm coming to RAZEENA. So, RAZEENA, thing is, Dr. Anne is from Bangalore. She knows the exact price. I don't know the exact price, but I know that few families are traveling to China to get it at a cheaper price. Definitely cheaper than India. One thing is how to make people understand, or do they understand they are denying that understanding? I'm asking about health policy makers. What are we going to do? What is the way forward? This is related to risdiplam alone. That is a oral medication. Dr. Anne feels this can help, not dramatically, but definitely there is some help. Bridging therapy, she's told, it has helped so many families. The ultimate aim is gene therapy. We have risdiplam now, but for that access itself, there are so many irregularities. What should we do? Or as a parental organization, what are you going to achieve in the future? What are your steps?
Okay, thank you very much for this question. First of all, with all my respect to Anne ma'am, she's my long back. I heard MDC is the mainstay for the children with SMA. Then MDC plus medicine only can give better outcome. All this I learned from ma'am only. With all due respect, I'm just in a difference of opinion about risdiplam, because I have seen patients from real world experience. We have seen patients who are provided risdiplam in an early stage. I mean, less than 3 months, less than 2 months. Now we have given with a prenatal diagnosis also, just 1 month before. The child is provided with medicine on 15th day. So we are having patients who were given risdiplam at an earlier age, less than 3 months. All those patients are comparable with the results of gene therapy. So I am also waiting. What is the outcome if we are having newborn screening here? we can have a better comparison, I hope.
Yeah, I will.
Then,
Yeah, 1 second. Yeah.
Yes.
Now, so I'll come to that. So we don't want to give you an opinion that this is an inferior drug or this is a superior drug.
No,
Depends on the presentation. We know how the drugs act. The pre-symptomatic or before the child develops some muscle loss, if we instill anything, it is going to be very, very helpful. Of course, risdiplam is going to work. Ma'am is talking about even little severe diseases where when you compare this one, that may be a better option.
This is a good point, she
Yes.
made, but I have one more answer to that. So the answer to that is, what does policymakers do? So policymakers have to think very carefully before they institute policy. So for me, one useful way of taking temperature is when the entire neuromuscular world, we meet once a year. Every year it's either in Canada, US, last year it was in Prague, this year it's in, I'll be going, in a few months' time I'll be going to Vienna. Every year we brag about US, this many states, Israel, Denmark, each country brags. And UK is going backwards. They have less resources, less and less resources. So when there is less resources, they pick up risdiplam. So this is the pattern that we have seen. So there are, so just like the newborn screenings, the prenatal that was done, the reason that Lucy was shown. So if you see, Lucy, the girl who was given gene therapy, was shown. Her video is shown. The other child given antenatally, not shown. She has brainstem abnormalities. So this is not about one drug against the other. It is about, it's a scientific thing. So at any given time, what medicine is not a perfect science. 2 years ago, when I was asked an opinion, gene therapy, is it useful below 2? I said no. I've changed my opinion now. I say yes. Until 3.5 years it works. So which is why European guidelines for it is different to American guidelines. And a lot of it is based on how much money the legislators are willing to pay. The pharma company is willing to pay and the insurance companies are willing to pay. So that is for another day. That is to create muddy waters, and that is about small pockets. Now, you're right about the NBS. We are a long way away from NBS. We're a long way away from NBS, and probably not my lifetime. I don't know. Because we have so many other problems to tackle. So I hope to reach at least where UK is. Maybe we'll overtake UK. Because UK has not got NBS strategy purely because they cannot, if they diagnose all of those children, they do not have the resources to treat them. So they don't want to pick. Don't see, don't know. It's as simple as that. We don't even want to know. It's not even don't see, don't know. So we are actually got a registry. So madam was telling me some 200, 300, how many registered patients that they have. Kerala population, nothing anywhere near. We are proudly selling, we have 10,000 people SMA. We have so many more. So I confess that my opinion is a biased one because I have been unfortunate enough to treat patients with only, I couldn't choose. Whatever I was given, I had to give. But looking at others and everything else, current policy, if I have to summarize, because we had a meeting in Dubai for all over the world doctors, and I had to present high income country versus a low middle income country, what is the policy differences on treating SMA. And the consensus is based on resources. And when all the resources are available, nobody's going for risdiplam. They're going for risdiplam if it is pre-symptomatic, higher copy numbers, and the parents are not worried. Because we think we are unnecessarily giving gene therapy. Gene therapy has risk to life. So there is a nuance there. First, safe, efficacious. Both are there. This might be, you might be right later on. But as it stands, today's future, we don't know. We don't know is the answer. So for now, we're going with what everybody is holding hands and saying this is the best decision. But it's a cautious decision. I may change my answer. Okay.
So from this, I would understand, or what I can see, or what is practical for me is the nearest answer is risdiplam for anybody.
Yeah.
So other than your Neuromuscular or your Zolgensma, I can see something I can access. There is a chance for a family to access is now risdiplam. Okay. So now you have a state policy. And in your state policy, if you want to implement a newborn screening, you are diagnosing an SMA, you are ready to give risdiplam on day 1. Think about me. I am doing a newborn screening here. That child turns out to be positive for SMA. I don't have risdiplam. So what should we do now? Or I have a child, no newborn screening. At 6 months I have diagnosed. Now what should I do from Coimbatore? And is there any chance that this is going to move forward? See, there are multiple states are there. Each state is having their own policy. But rare diseases policy comes from the center. Is there a chance to get a uniform policy from the center for these medications because you are proving in your state. Can this be used to convince the health policymakers to make it as a uniform rule across India? Is it possible in the near future?
For this question, I think there should be a collaboration between the patient advocacy, what we have seen, what we have observed, what is the statistical evaluation of that, the results we have got. We should communicate this through our healthcare professionals to other states also. We need to convince the policymakers with the result what we observed, with the result in Indian population. More than 100 patients we have on risdiplam. With that result, we have to approach the policymakers. We have to make them understand what is the result of earlier treatment access. That is one way. And the other thing is where we lack is we are not having any central registry as of now. But now ICMR is on the way and they have started collecting information from the COEs, and I am also a part of helping that from my state, and here Selvastri Priya, she is also helping for COE registration. From the COEs, ICMR has now started collecting the data and they are making it the central registry, and as per the information I got, it will be completed as a perfect registry in 2 years, but now itself it is into practice, and we will be having that data for anyone who is ready to invest here from the pharma side. That is one thing I believe much promising. And then is the infrastructure that is improving day by day in rare diseases and for other neuromuscular diseases.
So,
all this.
Thank you. Yeah. So you brought out that word, Center of Excellence.
Yes.
Are you giving this risdiplam through Center of Excellence in Kerala?
In Kerala, we are having state policy, and in Kerala, we are giving the medicine through SAT hospital, which is our COE, but it is not under COE funding. It is under state funding only.
Great.
The state earlier that was the collected fund, but the state has started giving means accepting donations for that.
So I hope you understand my point behind that question. Yeah. So it is a COE, state government funding. I can understand
Yes.
SMA funding is separately done by Kerala state government, where the funds go to that trust, and from there you are utilizing for the medication.
Yes.
But it is given through COE. So it means that even it is not, the funding is not from COE. I can understand. But the doctor, the setup, evaluation are done through COE,
sir.
right?
No, sir. It is under state government only. SAT hospital is a part of it.
We are trying to demarcate by saying that. So, in Kerala state, that is a COE. SAT
Yeah, that is
hospital,
SAT hospital is the COE.
Is it designated
Yes,
COE?
it
So
is
through
designated
that.
COE.
We're not calling it a COE
Yes.
center.
Okay.
Not center names here. So it's through the COE.
Yeah.
It is through the COE. So the COE there, the people there understand that this is working.
Yeah, this
Whose
is working.
funding? You leave it. We have an
Yes,
answer.
This is working. This is working.
For one COE, families are getting medications. It is working in one COE.
You have to go to SAT and get it.
You have to go to
The
SAT and get it. That is the
data it
COE.
is possible.
Huh?
Yes, data it is possible.
Okay, this
Yes,
is
sir.
possible.
Yes.
So can we replicate the same in all other COEs? Is the next question. Funding you leave. You want to prove. If
Yeah,
we cannot wait for 2 years, we cannot wait for 2 years, collect all the patients list and start this. There is one center in front of my eyes who is doing well. They have all your proof that it is working, and you have got enough number of patients. And it is through COE. It is not through Baptist or not through ANT. It is through COE. And we have 12 or 18 COEs across India.
13 COEs are there.
Can we apply the same, or can we share this knowledge to the COEs, influence the COEs that this is working? Because I am feeling some difficulties. I am facing some difficulties from COE of Tamil Nadu itself. There are no strong recommendations.
Sir, from the patient advocacy part, I can help this through the COE Nodal Officer Kerala.
Yeah. So
with
if this is communicated to the COEs, they can put forward that this will work. There there is a difficulty there itself. Our patients go get registered in COE in Tamil Nadu. There are no strong recommendations from the doctors. We are facing that. They may have some practical difficulties, but I just want a uniform protocol. If it starts from Kerala and it is applied all over the COEs, then we can get some answer. That is my whole point I want to make.
Currently, as far as I know, only ESI, Railways, Air, Armed Forces and what is the other one? CGHS.
Yes,
Yeah.
yes.
Only
But
CGHS,
very
they are
less
the only
patients.
people. They are very less patients because that's the only population they cover. Only these people get it. And ESI has the longest waiting list. They vet and vet and vet. And they've rejected some of my patients here in the group. They've rejected the claims. I've had neurology colleagues, adult neurology colleagues who've said, this medicine doesn't work. I've written prescription letters, it doesn't work. So COE, what you said, name COE, I have a COE in my state. I have a COE in my state. And they had somebody who came to fund said 50 patients, Kodunga, we will give free. Nothing happened. And they didn't have the 50 patients in the registry. They borrowed our 50 patients, we gave it, nothing happened. But I guess because we are a democracy, responsibility is ours, we the people, to keep making ourselves heard.
So I'll move on to the next. This is an important topic. It is worth spending some time. That is why I spent a long time with you both regarding the newer therapies and the accessibility. Next comes the deformities, prevention, rehabilitation, when to think about surgery. Surgery is too late. We have missed the bus if a child goes to surgery. So Dr. Venkatas is left for an emergency surgery. So maybe you both can cover this topic. Deformities.
Give some examples of deformities.
Okay. So most often, I'll just talk only about SMA here. We're usually looking at your hip, knee, ankle. That is what initially we used to really focus on. We're also starting to look at your upper limbs also now, simply because we want them to be more independent. So that is what we can call a shift in focus as far as the rehab is concerned. Of course, you have your scoliosis. Do you want to answer the scoliosis?
Before that, I'm just giving one context. The first time I saw SMA patients, it was in 2019. Normal patients came to us, motivated families came to us. 2019, when they announced Spinraza saying, oh, some patients will get free, my goodness, it was heartbreaking. It was really depressing. There were patients who were not able to sit. They were carried, literally, biblical terms, carried and lowered down kind of thing. They were carried in stretchers. They were brought from Kerala, from Andhra, from Tamil Nadu, all of those places. It just showed that the deformities exclude people from mainstream life. And then it becomes very difficult to reincorporate it, include them into normal life. I really felt very strongly we are letting all these people down. To let it to that level and almost that they disappear and go away. So preventing that is worth it. So which is why I do everything with her.
Yeah, so we have a lot of orthotics options now. So orthotics is changed dramatically in terms of what materials we use. So now a lot of it is lightweight. It's easier. It's more comfortable for the child and the parents to use. It's just that there's a reluctance, and that reluctance, once we overcome, I feel like we're really advancing. So people say, okay, from UK, that there was a child in UK who can't get orthotics there, goes to Italy. We said we can do this here, and we did it here. So it is available, and there are people who are already making it here. So I think that's definitely something that we are on par with in terms of developed countries.
Sometimes even better as well. So maybe we have a selection bias in the sense that we only get motivated families. Because India is self-funded healthcare. We can't be doing everything free because, how much of a motivation is there? I have to pay the staff and the rent and all those things. But still, certain amount of it we can waive off and things. So the families who come to us, that other family, Dia's mother, amazing, no? So they have taught us. We've learned from them. You've learned from Dia's quite a bit. Maybe you should talk about this PO and other things.
Yeah, so this is the same child that we had discussed about the non-invasive spinal cord stimulation. So this family, physiotherapist mom, so she finds everything that is there available abroad, somehow manages to import it here. And so now you translate, so you translate that to our Indian population, see how we are able to find it here. So something that was 45,000 now we are able to get for maybe 7,000. So I think we as I feel like we have enough knowledge to use our materials and make things available and accessible for our children, which we are doing. So I think that way deformities. So a lot of people say, why are the children abroad not as deformed as the children here? That is something it's a very striking question.
Yeah, it is very striking. They are out in the public. Our children are not out in the public, so which is heartbreaking. But the surgeons now, we are beginning to use surgery quite judiciously. So we work very closely with our surgical team, both the spine surgeon and the orthopedic surgeon. Abroad, we used to have specific ankle neuromuscular clinic, shoulder clinic, spine clinic, because there were only doctors who were doing only spine, doctors who did only shoulders, doctors who did only ankles or hands. But our job is to prevent. But once you reach there, then we operate. But then it is a continuum of care. It is not just a surgeon. Surgeon will say, okay, I'll come and fix, carpenter. But we do pre and post. We make sure that the surgeon is going to use metallic implants to fix it. But we need to make sure that the implants, as physicians, that they stay, that you're giving zoludinate, that you're doing it at the right time. So previously we were a little bit worried about giving zoludinate too early after implants and stuff. Now that fear is gone. So we've learned enough our lessons. We've learned enough lessons from that to be able to be comfortable to use these instruments and tools. Does that answer your question?
Yes, ma'am. But my another worry or concern is we are looking at the treatment options, lakhs and crores, and we have something which can be done, which is in our hands. And are we missing on that? That is a straightforward question. So
We really are actually. So, like for example, now there's an orthotic center, and we have it in Baptist. Again, there are complex orthotics that children travel from all over the place just to come to get one splint, which I feel like this is easily translatable. We are not talking about crores here. So we set up our orthotic center with actually, it is actually the cheapest orthotic center. Within 8 lakhs we set it up. So that setup is not impossible. And each splint, like people are talking about, you can go to like an MNC and get the same splint for maybe 18,000 rupees. We give it for 4,500 rupees. So what you're saying, it is
generic
definitely
splints.
No, Indian
Yeah,
made.
so
Desi
Indian
made,
made.
not
So
multinational companies.
true.
Desi made.
So thing is, now the question is, we were talking about all these medications, accessibility, we have to run here and there. There are so many things which we can do. First thing is, நம்மளால என்ன பண்ண முடியுங்கிறத பார்த்துட்டு தான் we have to ask for help. So we have to make sure we have done our job. That is where the rehabilitation consultants, that is where the neuromuscular specialist, bone health, nutritional health, all these comes into picture. These are basements.
நல்ல பாயிண்ட் பண்ணீங்க. நியூட்ரிஷன் சரியில்லைனா you do all of that, the screw will break through and the skin will not heal. It's this breakthrough, no? It will not heal.
So all these has to be taken care of, particularly nutrition. If you want to put food inside the stomach, if that is a struggle for you, leave the struggle to the gastrostomy tube. At least you can take care of something else. You can put your energy on something else rather than spending on feeding the children carefully, avoiding aspiration. So put a tube, give all the nutrition whatever needed so that the stomach digests and get it, rather than fighting with the child, feeding it safely, so that you can put your thinking, your energy in something else like stretching, avoiding contractures, giving orthosis. Okay, so respiratory care, sorry sir, we made you wait for a long time. We are coming to you after a long time. So respiratory care thing is, in neuromuscular disorders, particularly SMA, what are all the preventive aspects we have to focus upon? When should we evaluate? And when should we think that this baby has some sleep hypoventilation, needs some help like BiPAP? So first is prevention. When should we evaluate? When should we come to a conclusion this child needs a respiratory support?
I think Dr. Ann and team have been role models, and they have a very good multidisciplinary team. And I usually talk to their pediatric pulmonologist, Dr. Eileen, who is of great help to us. And lots of things we learned from them, basically. And initially, we were not very aggressive with management of SMA patients, we have to admit. And then, whenever we have a patient, we tend to refer to them as early as possible. That's what we were doing. And sometimes we have some patients, we do joint care with their team. And most of the, like type 1 SMA, when they present with, respiratory failure to begin with, or some kind of respiratory infection. And the thing is, they usually have, when we have a child with a paradoxical respiration, we have to think of, when a hypotonic child, we have to think of SMA. The early diagnosis is very important, because whatever treatment you give is important. The disease modifying therapy is going to change the natural course of the disease. Therefore, we have to pick before they develop respiratory failure. Clinically, if it is a type 1 SMA, if the child is hypotonic and having paradoxical respiration, at that time itself child is having respiratory failure. We can't rely upon saturations. Saturations will be initially normal even in hyperventilation, and blood gases during the daytime can also be normal to begin with. Blood gas, if you rely on blood gas, sometimes it can be normal, but we have to look at the PCO2. It will be usually, if it is daytime hyperventilation, it will be more than 45. And if there is a chronic respiratory failure, bicarbonate on your blood gas will be elevated. These are some clues for babies. But whenever a child is admitted, definitely nighttime desaturation is one of the things we look at. If a child desaturates, especially in night also you have a predominant NREM sleep and REM sleep. The REM sleep occurs during the early morning. Therefore, desaturation in the early morning is an indicator. And if you do a blood gas early morning, that might tell you there might be some hyperventilation. But the best thing you have to do is do a sleep study. But if you don't have facilities, the child has paradoxical respiration, or if there is hypercapnia, you straight away go in for non-invasive ventilation and find ways to get the drug. And if it is a type 2 or type 3 SMA, you can go for a proper sleep study. Sleep study can be done even in infants. Previously, the facility was not available. Now we are doing sleep studies here. We have at our hospital, and level 1 sleep study, proper PSG, and we have a transcutaneous CO2 monitor as well. Therefore, we can pick up hyperventilation early. If you don't have a transcutaneous CO2, it's difficult. You can just pick up obstructive sleep apnea and desaturations. But the important thing to pick up is like nocturnal, hyperventilation. For that, you need to have a transcutaneous CO2 monitor. We do have that. Therefore, doing the sleep study is the best thing. In older kids, if it is type 2 or type 3 SMA, probably if the child is old enough, we can do a lung function testing and look for FEC and a peak cough flow. For effectiveness of cough, if you ask the child to cough, you'll know. But easier method will be to do an objective measurement using a peak cough flow. That's a usual, peak flow meter. You have to ask them to cough on the peak flow meter. Take three readings, and best reading should be about 270. If it is less than 150 itself, this child will think, this child doesn't have effective cough. This child will need BiPAP plus or minus your cough assist machine. Did I answer your question?
Definitely,
what was the question?
Definitely, 360 degrees. So started from prevention wise, and vaccinations.
I think
vaccinations.
early diagnosis is the key. Early diagnosis is the key. And as Anne said, you have to start them on non-invasive ventilation at the earliest. And we don't have access to cough assist device, but therefore, I think we have to give the option of cough assist device to the parents. And easier available thing is, get hold of a physiotherapist, teach them how to clear the airways. That will definitely help. And all these patients will have bulbar palsy. Therefore, there is a risk of aspiration. Therefore, if there is pooling of secretions, you have to give a proper suction machine and then teach them how to do that. And second thing is the cough device, and you have to assess for swallowing as well. And here, what we do is refer them to a speech therapist. Speech therapist is available. They actually observe the child while feeding. That will give a gross assessment. Sometimes that can miss. It's not very sensitive method. You have to do a video fluoroscopy swallow study. That's widely available, man, in most of the centers. But there is a risk of aspiration, and fees also you don't do it. Fees, assess them clinically. Yeah. So, okay. Therefore, if there is a risk of aspiration, as ma'am said, to begin with, we put a NG tube and manage them until they 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 give consent for gastrostomy tube. But again, what I feel is it's difficult to convince our patients. And what is your experience regarding gastrostomy?
Very difficult, sir.
Very difficult to convince.
And so it is not like you cannot, it becomes a more of a subjective opinion
Okay.
than a
Yeah.
objective thing. You
And
go,
what
because
are-
we need to refer them to a gastroenterologist.
Yeah,
There
yeah,
again,
yeah.
we get that
And-
feedback. Oh,
Yeah.
you really want to do this.
And another
Yeah.
thing,
So-
what I do personally is, ask the parents to talk to the parent who is already having gastrostomy tube. That really helps, And again, what we feel here is, like, if you are doing gastrostomy once in a blue moon, there are some complications, therefore, it doesn't work like that. Therefore, we had some bad experiences. Therefore, it's better to go to a center of excellence where they do it very frequently.
I
That's
agree
why-
with you on
yeah,
that.
Yeah,
Because I work in 4 or 5 hospitals in Bangalore.
Yeah.
But gastrostomy I will do only in Baptist.
yeah.
Because they are doing it so frequently.
So frequently, yeah.
Otherwise, I'll have my surgeon come and tell me, I did fundoplication, but I got a partial fundoplication.
Yeah,
There's
yeah.
no such thing as a
Yeah,
partial
I think,
fundoplication. It's either yes or no.
Yeah. For certain things, we have to refer to center of excellence because their experience is, we want better outcomes for the patient. Therefore, whatever best for the patient, we have to do it. And regarding vaccinations, it's an important prevention. And flu vaccine, I think it has to be given early. We did one study actually, like what the general trend is, we tend to give a little bit late, August, September. Our flu season starts end of June. We already have flu positive patients in our hospital. Therefore, if you want to give flu vaccine, give it early. End of June itself, we have to give flu vaccination, and we have to talk about some simple things like indoor air pollution. It will be there, that's very air pollution, air pollution, and masking also. They have to be very careful, not getting an infection. Yeah.
Particularly in Coimbatore, we see so much of indoor pollution is there, ma'am. Of course, we are surrounded by mills, textile mills, and you can see all the cotton fibers. Even if you think you're in a safest place, you see deposits, so which we will not know actually unless we develop an allergy.
Lots of agarbatti, all those stuff is here. Therefore, you damage the airways, and it's easier for the bugs to invade your lungs. Therefore,
So after the first question, whatever we are talking is related to what we do. We can do it in day-to-day practice, daily routine. Please.
Dr. Terence, with your permission, can I add? Dr. Terence has covered everything, but I'm going to summarize it by saying that we know the history. So we don't jump and, so as a pediatrician, first make sure that you've got a hypoxic child. Please bear in mind, if this child if you suspect it is hyperventilating, don't treat with oxygen, treat with pressure. And proactively treat, not reactively treat. Reactively treat, outcomes are not good. Everybody gets frustrated. The parent who has a chronically ill child, longer hospital stay, financial burden, everything is exhausted, and this is how all of us get depressed in the end. So proactive versus reactive. And the gastrostomy, I have one answer to that. Over the years, I think I've gotten either more scary or more convincing. It seems to become easier. So we are about to give our 35th gene therapy in the next few weeks. And that parent, they're from Maharashtra, they're just convinced, just like that. No problems whatsoever. So my surgeon was like, usually our gastrostomy patients stay for 1 week or 2 weeks, something like that. 5th day, this child was discharged. He's like, that's because I have not given him a complicated, already fully messed up child. I've given him a child which was straightforward. Everything went textbook. So we are getting there where we are able to do it. Initially, last few years ago, I have to say, some of my patients as well, they were very good in the sense, patients sitting in the waiting area would tell another patient, my child doesn't have it control. You have this, you are not doing it, very easy. So in the waiting area, there are so many parents, each one talking to them, mine has got this, you don't have it. Easy for us. So usually, mega OPDs as well has the same benefit. We don't have to, waste our breath or, feel breathless explaining the same thing. We are very convinced about it. They're like, no, my child doesn't have swallowing problems. And we know now we know targeted how to hit the history. So we say, 5-month-old baby with a SMA, paradoxical breathing is there. You are convinced there is swallowing therapy, but the parents are thinking you're crazy. You read something in a textbook and you're saying your child has got swallowing difficulty, you don't. So we usually ask and say, okay, problem illala, weight kammi agudilla, it's trailing off. They say, okay, eppo suck rest cycle. You can hit them with pointed questions, get them to reach that awareness that, yeah, this is it. And it is denial and grief. We're going to have to support them through denial and grief. But if we don't go, this dance is like a deadlock and it is miserable for them and for us.
Okay. So the last slide is for Dr. RAZEENA about advocacy.
I always tell my members in Tamil Nadu, it is not a one-day result or one-day game. It was a long journey in Kerala also. We had to convince so many people. But finally, we got the good result. But I think the Tamil Nadu people, they have already done the initial steps. They have met the politicians, all of, I think, most of the legislatures, they have met the politicians and all. There was a time when out of 140, 70 MLAs and out of 20, 12 MPs were met by our members and explained the cause. It was the starting of the journey, and we had very good support from the HCPs. We had SMA clinic in two hospitals. One was a full-fledged, the other one was supporting occasionally. And for the doctors also, we had, as per Ann ma'am, some guidance, we had done some HCP. Yes, initially, very long back story. Initially for the HCP awareness, some classes we had done. So we had the support from healthcare professionals. Through that, we advanced to the politicians with the right kind of advocacy work, I think, because they were also ready to support us through their letters to the ministry. And along with that, we advanced with our proposal. Initial request was for establishing an SMA clinic in the government sector, in the government medical college. That later turned out to be the COE. With the recognition of that SMA clinic, that was a success. Then was the request for the patient registry. Along with the SMA clinic, the government had started collecting the data, and we had we were continuing with our awareness programs throughout the state, through visual media, print media, also through social media platforms. So we were getting this cases diagnosed from the periphery, all directed to either pure SMA or straightly to the state government hospital. So this was the initial step. Thereafter, we started advocating for the funding, but there was a long block. Unfortunately, at that time, I will never say fortunate that word because it is associated with a death. But one side, there were two patients actually. One was Imran. He was 6 months only, and he was awaiting gene therapy after collecting the fund. On the day it hit 18 crore, that was the price at that time. The child passed away. So with that 18 crore, another child was Matul Muhammad. They collected 48 crore, but that child is alive. He got gene therapy, but there was excess fund. From that fund, 2 more gene therapy patients got support. After that, we had a lump sum amount of around 32 crore. With that, we had approached the state high court through the high court directive to the government. So the government supported us. Initially, the fund was that collected amount. Later, government started adding to it. That was the, and here what I want to add is the initial struggle for the funding was met with through public collected crowdfunding.
Shall I ask you a
That
question?
was the-
Yeah.
What is the critical bottleneck? I think is it the starting of the SMA clinic?
Starting of SMA clinic, it was easier actually. That is again my advice to my members, because I always tell them, don't give too many asks to the government, because they will be giving what is easier for them. So if you are asking the government, requesting the government to support with funding, ask only for funding. Others, it is easier to access through even from private sector also. But,
Oh,
yes.
yes.
Yes, ma'am.
Only thing I'm going to add to this is, I'm not sure, because you live in Kerala, so I don't live in Kerala, I live in Bangalore. My family is from Kerala. So I identify myself with Bangalore. When we started the first session where we had 100 patients plus we saw, disproportionate number came from Kerala. So even now we have, so for example, DMD, we have 13 patients who are getting 5 crore rupees medicines, they're getting it free of charge. 6 patients are from Kerala. 2 are from Maharashtra, 1 from Calcutta, rest from here, Bangalore. So this is, I think this healthcare is accessible with more awareness and education. This is literacy.
Yes, yes, yes.
Realities
There
are
is,
different.
yes,
Yeah.
yes. There is a difference. There's a difference.
Maybe
I
to
accept it.
answer Dr. Anthony's, what I got from your question is, the bottleneck is money.
Awareness here. Money, we have so
No,
much.
from the government perspective.
Money.
Awareness, of course, from the public perspective. Well, how much awareness you create, there should be some funding for the government to
Not
help.
really. After that, 32 lakhs crores would have gone
That is where I'm coming. So the breakthrough is the money. They've got it.
Money.
Maybe
Through's
I
money.
can say that they were at that point and they got that no, everything. No, I'm just viewing that in that way, ma'am.
But sir,
No, I'm coming to that point. No, everywhere, wherever we go, we have traveled together. We have met a few people, so who can influence it. So everywhere, what we face the bottleneck is the money. How much government is going to release for this? Is it worth doing it? Because their viewpoint is the same. My question is, to initiate this, you had some money, corpus funding. Is it possible in any way to get that funding? We have NHM funding. We have rare diseases fund 50 lakhs for a child. Or we can, as a Cure SMA or a patient advocacy group, you can raise funding for one state, not for one child. I'm just trying some resources. I'm just looking for some resources. That's all. Maybe this may look weird, but I'm telling you, is it possible to pull something from somewhere? So you have this money, sir. I have this money. Just start up this. Kerala has done this. Is it possible, or is it any way practical to do that?
I am coming into it, sir. I agree with that. The bottleneck was money only. But at that time, we were not having this result in hand. We were not having any COE support at that time. But now, I think SGPGI Lucknow has started giving, through COE, 5 patients are served, SMA patients. Through COE, some other state also, 2 patients got access. They are all smaller children, less than 5 years, I think. But through COE, the government has started supporting SMA children. That is one thing. And in one state, we are having an example. No, I'm telling about Kerala only. In one state, we are having this example. And now our funding, that initial corpus fund, that is also almost burnt up. So we are into the ground again. And we got this support from the public funded money only. It is not from any other support.
Yes.
The
I'm asking
public
this 50
funded-
lakhs for a child.
Yes.
Is it possible to pull up and make it a corpus fund? We have hundreds of children.
Pull up, it is not my take.
It's category 3 where the 50 lakhs is not released. So NPRD has got 1, 2, 3 category, no? The third category, SMA, DMD don't come into it.
But
Ma'am, some patients have got it recently.
Through the government? you've
Yes,
managed to get-
COE, through COE.
But is it through the NPRD?
Yes,
National Guarantee?
yes,
They're
yes,
not
yes,
Okay, that is-
yes,
that is-
yes. It is recent. It is very recent. And in our case also, say by 23 years, yes,
That is
yes,
progress.
yes.
So keep
Yes.
knocking.
so
Yes.
we are just trying to we cannot, as doctors, we cannot go ask the government to do this and that. You go, they'll at least hear from you. Okay, so I'm just trying to find some solutions. We have knocked NHM doors, we have knocked health ministry, everywhere we have knocked. I'm just telling you what is possible. So, if there's any final comments, ma'am, then we can go for question answers. So, if there are no further comments from our side, we will go back to.
Again,
I'll
one
come
more thing.
there.
We are recently we are getting support from some charity foundations and CSR foundations in Kerala. That is also one potential route we can try in any state. CSR.